Good morning. Good morning, ladies and gentlemen, distinguished guests and esteemed colleagues. As the chairman of MMA Slango, it's my honor to stand before you at this outstanding cardiology symposium organized by SJMC. It brings me a great joy to see our continued collaboration with SJMC, which has resulted in many successful events over the years. Our partnership is built on shared values and a mutual commitment to advancing medical excellence in Malaysia. SJMC has consistently demonstrated excellence not only in the field of cardiology, but across many other medical disciplines as well. The hospital's dedication to state-of-the-art facilities and innovative care in cardiology is truly commendable. And we at MMA Slango are proud to be associated with such forward-thinking institution. Together, we are raising the standards of healthcare for our community. Today's symposium represents more than just a gathering of experts. It is a platform of exchanging ideas, sharing the latest research and inspiring one another to push the boundaries of cardiovascular medicine. I'm confident that the sessions ahead will spark insightful discussions and foster connections that benefit not only our professional growth, but most importantly, the well-being of our patients. Before I conclude, I would like to take this opportunity to encourage all of you to become members of Malaysian Medical Association. By joining us, we can work hand in hand on future initiatives, support each other professionally, and strengthen our medical fraternity. SJMC will always be a valued and trusted partner for MMA Slango, and we look forward to many collaborations to come. I wish to everyone a productive and inspiring symposium. May our conversation today lead to new ideas, stronger collaborations, and better outcomes for our patients. Thank you, and all the best for the successful event.
Thank you very much, Dr. Krishna Kumaran. We are truly grateful for the continued support from MMA Selangor. On behalf of Subang Jaya Medical Centre, we would like to invite Dr. Jaya Malarajadore to present Dr. Krishna Kumaran with a token of appreciation. Thank you very much, Doctor.
And with that, I think we will start with the first session. As is our usual practice, we tend to have it as a case discussion because we think that rather than formal lectures, we think that the learning from both sides will probably be better. It is my pleasure to invite my colleagues, Dr. S.P. Chan, Dr. Shama Prasad and Dr. Shamruz may be on stage, and basically it will be case presentations, and they will be giving their viewpoints of how to treat some very common conditions that we find among our patients. And if you have any different viewpoints, any different questions, please, or answers, please share with us. Yeah. Whereas Dr. Prasad is still putting on his armor, ready for battle. Okay, so the theme of our talk is actually, is there anything new in cardiology, or is it all same old, same old? Are we talking about the same things? And the first session will be on what you have increasingly being heard. I mean, up to 4 or 5 years ago, we never heard of this term, cardio-kidney metabolic syndrome. And the other case we'll be discussing will be hypertension, what's new in the guidelines. So, first question is to Dr. Prasad. Maybe Dr. Prasad, you can tell us, share with us, what is this cardio-kidney metabolic syndrome? Is a kidney trying to wriggle themselves into the scenario? Yes. You can actually see it here.
Right, thank you, Jaya. Now, this, okay, most of us have known that, that from a long time, that there is a, how to point? No need to point, but for you to change the slide. Oh, definitely. that there is a bidirectional relationship between the kidneys and the heart. And in fact, it was the relationship was been mentioned, and if you look at the Old Testament and even in the Egyptian Book of the Dead, they talk about the kidneys and the heart. And Richard Bright, who was a guru of all glomerular diseases, talked about a hypertensive heart in patients with glomerulonephritis. The term cardiorenal syndrome was coined somewhere in the early 1913 or so, but was formalized. We called it the initially cardiorenal syndrome in 2004, where people tried to, the American Heart Association convened a meeting among cardiologists and nephrologists and physicians, and they came up with this concept of a cardiorenal syndrome. But later on, they found that there were many other things, including metabolic diseases. And in 2023, again, the AHA, American Heart Association, taking the lead, brought in this term cardiovascular kidney metabolic syndrome. And as you can see here, these are all the three main ones. What are the risk factors? Now, let's start from the lower part of it. Lifestyle factors, which include smoking, inadequate physical activity, poor nutrition. By poor nutrition, I mean people who take diet which is full of saturated fats, trans fats, and so on and so forth. A diet which is has not got enough fruits, vegetables, and so on and so forth. So these are lifestyle factors which can cause this. Chronic inflammation. Now this chronic inflammation in this case is usually driven by the adipose tissue in the body. So the more fat cells you have, the more inflammation you have. Now this chronic inflammation is caused by the release of certain substances, cytokines, from the fatty tissue, which causes a low-grade chronic inflammation. Kidney disease, which not only we talk about GFR or kidney function, also the presence of proteinuria. Any increase in proteinuria causes an increase in cardiovascular disease, and this is already well established. Now, we talk about obesity and adiposity, and this is so-called the apple-shaped body, you know, where you have truncal obesity, more fat in the abdomen, and while your thighs and your legs all remain small and slim. Dyslipidemias, mainly an increase in triglycerides, low HDL, and a slight increase in your LDL cholesterol. High blood pressure, of course, goes without saying, and metabolic problems like, of course, obesity I've mentioned, and type 2 diabetes. All these are risk factors for the cardiovascular kidney metabolic syndrome. Now, this has been staged at that time in 2023 into stage 1 to stage 4, that means 5. Stage 0 is when there's actually no risk factors, I mean, in the sense that you are not, but this is where you feel, if, as a general practitioner, if you see a patient, this is where you must tell them to be proactive and to try and prevent the development of cardiovascular kidney metabolic syndrome. Stage 1, of course, when you have visceral obesity, you find that the patient is putting on weight, especially truncal obesity, they become overweight and so on, your BMI is high. Then in stage 2, they have visceral obesity plus metabolic disorders, and the metabolic disorders mainly include your diabetes, your hypertension, and your dyslipidemias. And in stage 3, you get subclinical cardiovascular disease. Therefore, patient has a lot of abnormalities, but they have no signs of cardio. They do not complain of chest pain. They do not complain of anything. But here you can actually check for any cardiovascular problems. Well, you can refer to a cardiologist for a CT angio. You can get an echo done, a simple ECG, to see whether there is any possible underlying cardiovascular disease. And of course, the last, or stage 4, where you have symptomatic cardiovascular disease. Patients have either angina, heart failure, and so on and so forth. And stage 4 is divided into 4A and 4B. 4A, where they have cardiovascular disease but no kidney problem, and 4B, where they have cardiovascular disease associated with kidney problem. And the last slide here, what is our management strategy? Of course, in stage 0, patients should be routinely screened and advised accordingly. When stage 1, of course, lifestyle modifications are very important, including diet, healthy diet, exercise and weight loss, smoking cessation, reduce alcohol intake, bring your weight down to your ideal body weight. Once they cross this and go into the stage 2, then you need intensive blood pressure and glucose management. Also, you have initiate cardio and renal protective medicines. And nowadays, we all talk about the use of ACE inhibitors, and especially the SGLT2 inhibitors. These are very important drugs nowadays, not only for the kidneys, but also for the heart. Okay? And now Dr. Chan will give us more information about the incretin-based therapy, which is definitely we consider in using in our patients with whom we want to intensify our therapy, although these are injectables and but now, because it's only once a week injection, it's actually catching up in more and more patients are learning to accept this. And of course, in advanced cases, in stage 4, you need secondary prevention of cardiovascular disease, heart failure management, and full management of all the metabolic problems, including renal disease, endocrine, etc., etc. So this is the nutshell of the cardiovascular kidney metabolic syndrome.
No risk factors. Life's essential 8. Actually, there's 9, but the 8 are: eat more fruits and vegetables, exercise, check your sugar, weight, lipids, blood pressure, stop smoking, and have adequate sleep. Sleep is now becoming a risk factor for cardiovascular disease. Sleep at least 7 to 8 hours a day. And the 9th is stress. Okay? And as has already been alluded on, stage 1, stage 2, stage 3, and on to stage 4. Okay, so now I shall pass over to Dr. Chan to present her case. Thank you very much.
Thank you very much, Jia. Right. I'll start with the metabolic part, and then these guys are going to continue to illustrate on the kidney cardiac aspect of it. I think that is just to illustrate that if you have a patient with diabetes, well, this thing works, but just about cannot see that. Type 2 diabetes and cardiovascular disease, then people with diabetes has 2 times the risk of, I think you know all this, I'm not going to go through it. So let me just show you this patient, right? I think you would probably recognize this patient as something you will be seeing or has seen in the recent weeks. She comes to you saying, Doc, I've been gaining weight, I've been trying to lose weight, I do this, I do that, and yet my weight keeps coming back. She has had 2 gestational diabetic pregnancies, and the GDM required insulin for control. Both her parents, unfortunately, have diabetes, and her mother had a stroke at 50s. She's a non-smoker, and she takes alcohol on occasions. BMI is 32, BP is 138, 80. And you look at her neck, and she has acanthosis, right? So the first thing that you'll be looking at here, quickly, just pan the history that I've given you. How many risk factors for type 2 diabetes and the cardiokidney metabolic syndrome does this woman have, and what investigations will you actually order for her? So, because I think I want to have more time spent on the management, I'm going to go quickly. So, she has, I'm sure you'll agree with me, multiple risk factors for being diabetic, isn't it? She's had gestational diabetes, diabetes. Unfortunately, her weight is high, very bad genetic background. Both her parents have type 2 diabetes. Her risk of being diabetic is in excess of about 70%. BP is on the high side, and you'll listen to more discussion around that. This one thing I want to start you off with is the new terminology for waist height ratio. Now you don't hear us talking about waist hip ratio, it's waist height. So waist versus the height, and then you will see that in fact anything above 0.5, more than 0.5 ratio means this person has too much enteral obesity, too much visceral obesity. So that's a new terminology you're going to come against. In her biochemistry, you will see that she is pre-diabetic with a fasting less than 7, that's pre-diabetes. 6.1 to 7, less than 7 is pre-diabetes. HbA1c, it doesn't come out. HbA1c is 6.2. So it depends on which guideline you use. Anywhere else in the world, 6.5 and above is diabetic. In Malaysia, unfortunately, is 6.3. Okay? She has got what Prasad talked to you about, the metabolic dyslipidemia, which is a low HDL, below 1.3 for a woman, and TG that's elevated more than 2.3. Okay? Lucky for her, her renal function is at the moment normal, and I've added there TSH to again identify that if she has a weight problem, she's got some abnormal lipids, think about whether or not she might be having hypothyroidism. So I think we will quickly go into the fact that she has what we diagnose here: pre-diabetes, clinical obesity, metabolic dyslipidemia, and a blood pressure that needs observation. Again, one more fact that you want to learn, the new advance in metabolic care is now we don't tell patients that you have obesity type 1, obesity type 2, this kind of thing. We make the diagnosis of clinical obesity, which means that there is measures of increased adiposity, as you heard from Prasad, right? Increased adiposity, whether you are waist height ratio or the body mass index. But in addition to that, the patient has clinical parameters that puts her in that clinical syndromes that you heard about, metabolic dyslipidemia and things like that. Okay? So clinical obesity, meaning they already have some clinical disorder relevant to the excess adiposity. So, first question, what will you do if she comes to you tomorrow and says, "Doc, please help me"? Will you do exercise and diet some more, join the gym, get a personal trainer, start her on metformin, give her incretin-based therapy, don't talk about cost, okay? SGLT2 or send her to the surgeon to do bariatric surgery. Maybe I'll ask Jaya. Jaya, what would you do?
A, and probably also B. A and B.
A and B, good. Prasad?
Yeah, I think lifestyle modification is the most important. If they can lose their weight and bring their BMI down, then although metformin in itself, I suppose, will help weight loss. So,
very
but a
minimal.
lot of my patients seem not to want to take medication. So they say, "Doctor, let me try to lose weight. Let me try this. Let me try that." So I usually give them a grace period where I try to not to start. But if they are open to the idea, yes, I do start.
Shamros,
Yeah, same.
are you his friend? Are you his friend or not his friend?
I am.
You are. Maybe you want to take this so that you can. Okay. If I were the patient, I would say, "Useless buggers. Yeah? I just told you I tried like crazy and still cannot lose weight. You wanted me to go back to personal trainer, right?" The problem with many patients, by the time they come to us, are likely to have tried multiple tries to lose weight and have, again, multiply lost, get a bit of weight loss and then they gain it back again. All right? So, metformin has a very little weight loss, but again, more GI side effects than anything else. SGLT2, some of you might be interested in trying that, especially since we know all the data around it. But unfortunately, its weight loss is also very mild. Okay? Metabolic surgery, I think most patients will not consider that because it is very invasive. Okay? So, okay, now, if she came to see you, no, Jaya and Shamrose, would you think there is enough clinical risk for you to say, let me have a further look at you cardiovascularly? Maybe start with Shamrose. What do you think?
Well, strictly speaking, if she doesn't have any symptoms, you don't really have to do like stress test, CT scan, calcium score at this point. But because she's pre-diabetic, borderline blood pressure, I would probably do ECG, KIV, echo maybe, depending on the ECG findings. But
Okay.
sometimes in this kind of patient, it's very hard to be objective about the symptoms,
Absolutely.
whether they really have symptoms or not.
Correct.
That's
And
the
most of them
question.
will not have symptoms, isn't it?
Yes.
Except they say, oh, you know, climbing a few flights of steps, I'm breathless.
Yes.
Yeah. Prasad, would you do anything to the blood pressure at all?
Today?
Blood pressure
Okay.
was 138.
What would you do? 13880.
138/80. Well, this patient still is not, is not yet hypertensive in that sense, but according to the new criteria, their blood pressure, systolic blood pressure is elevated, but I would still go with lifestyle modification. I would not start on any blood pressure medicine at this stage.
Just lifestyle and then monitor the blood pressure.
Blood pressure,
But what to
correct.
do? Would you ask her to perhaps take less salt, sleep better?
Yeah, definitely. So as Jaya was mentioning there, they are the so-called Life's Essential 8. I think one of the most important things we talk about is salt restriction. Quite difficult in our Malaysian scenario where you go out and eat a lot of hawker food. But if you eat at home, less than 5 grams of salt a day, which is roughly equals to slightly more than 1 teaspoon of salt, adequate, that itself should reduce your blood pressure by about 5 millimeters of mercury. Adequate sleep, very important. Rule out anything like sleep apnea syndrome, which is something which is very rarely diagnosed, although many of our patients who are especially big size, obese, tend to have some, so inquire about snoring, daytime somnolence, and so on and so forth. Then get them to lose weight, and check on their stress level. Stress level is something very subjective because it's something that you cannot, if they're working, you cannot tell them to resign from their job and so on and so forth. So that's pretty subjective.
Okay, Jay, I'm going to ask you this question. She's got a poor family history. Her mother died of a vascular event relatively young. Okay? What are your thoughts on what we know about pre-diabetic individuals having already cardiovascular risk at the time that they are pre-diabetic?
Actually, I would besides doing the ECG, I would probably ask her just to do a calcium score. If the calcium score is elevated, then I'll say, hey, you got to get all these down because your mother only had it at 50, which is quite young, very young. So calcium score, I'm increasingly doing more calcium scores and CTAs compared to what I used to do maybe 2-3 years ago.
Yeah. Because I think I want to again emphasize, this is a woman who's 39, who's still having her periods, and many of us believe that if you're having your periods that you are protected. But once they develop diabetes, and perhaps even in the pre-diabetic phase, they already behave differently.
Yeah. In fact, I have a 38-year-old lady, just diabetic for about 1 or 2 years, angios triple vessel disease. So
really frightening. So don't underestimate. If you have a patient who is diabetic, even if she's premenopausal, treat her as if she has cardiovascular disease. So, well, typical, expected. She says, look, doc, I want to try lifestyle. You guys, SP Chan was too aggressive here, right? She ran away and then didn't come back until 3 years later. And now, like in most normal real world experience, the patient has gained weight, waist-height ratio has jumped up, and then she says, no, over the last 3 years, my weight goes down, then goes back up, comes down, and when I have festive season, like Chinese New Year, comes back up, right? And then up and down. Okay, now she looks different. Her fasting glucose A1C is clearly in the diabetic range. Her HDL remains low, her triglyceride remains high, and the calculated LDL is there. Okay? And her renal function, which used to be normal, is no longer normal, and the urine ACR is starting to be positive. Positive would be anything above 3. Okay? So, doctors, my colleagues, what would you do for her now? Would you knock her on the head and do a SP Chan special? Shamrose?
Gonna have to be very aggressive now. Do ABC.
ABC?
Maybe not D.
ABC? Prasad?
Right. I think definitely A, diet and exercise. Even though she's tried and failed, but see, this is what they do. And every first time the festive season comes around, they put on weight, and so on and so forth. They say they lose weight during Posa month, but after Hari Raya, they put it all back again. And B, definitely metformin plus SGL2.
Yeah.
So I would go with A and B at this point of time.
Jaya?
Yeah, I think so. Start one thing at a time. A, B, definitely. And the next one, if it doesn't come, would be a C.
Okay, right. So now the husband says she snores. I cannot sleep because she's so noisy. Right? What does that sound like?
Sleep apnea, obviously.
Okay.
So
Right.
we always ask about history of snoring and daytime somnolence. I think these are the two key parameters that they can actually relate to you. The choking at night, of course, is not something they will tell you, complain, but the partner will always complain that
yep.
there's choking sensation at night.
So what do you think you could recommend for her sleep disorder, since Prasad, you mentioned about choking as a sign of OSA?
Well, I would just get a plethysmography done. You do a sleep study.
Yes.
And then get that done, and then...
Can you maybe just quickly describe what are the options for sleep study now, today, available?
Actually, I mean, of course, it can be done in hospital, but unfortunately, we all know it's not covered by insurance.
Very expensive as well.
It's expensive. But you get all these companies that provide or sell these sleep apnea machines. You can contact them. They will come to your house and do this polysomnography. And you can actually, and it's pretty cheap. It's a few hundred ringgit.
Yep.
And they will come and do it in your house. And then they will give you a score. And then you look at the apnea-hypopnea score.
Absolutely.
And then you decide whether they want. Usually they will do all the settings, etc. for you. All they want you is to buy the machine from that particular company. And there are lots of them available in the market. And
so what Prasad is describing is that we can now order a home-based sleep study. You don't need to pay a lot of money. They will strap you up with oximeter plus something around your chest to look at your respiratory excursions, and they can do it from home. And when you send, the results will be whatever in the cloud, and then you go to the doctor who requested it, and they will look at it and tell you whether that you have obstructive sleep apnea according to definition. And if you do have it, then there are treatments available. Okay? So
basically, the treatment is to get this machine, which assists you.
They call it a PAP.
CPAP.
Okay. Right. Let me ask Jaya and Shamrose, what would you recommend to target for her LDL as well as perhaps weight loss?
I mean, the LDL without known underlying coronary artery disease for her at this stage, below 2.6 at least. If you can get it below 1.8, even better. Weight loss, usually we say 5 to 10% weight reduction. HbA1c, 6.5 to 7 still? Is that the range?
Yeah, okay. So, Jaya, since Shamrose brought up the thought, difficult for you to target a specific LDL target unless you know more about her clinical cardiovascular status. Would you investigate that?
I think just do a calcium score first. If the calcium score is 0, then I will just put it as Shamrose says, 2.6. But if the calcium score is elevated, then of course you have to have a lower score and investigate further.
You wanted to say something? Okay. So if the calcium score was how much? If the calcium score was how much?
Actually, is anything above 0 means it's already some plaque build-up already. This is a calcified plaque. But actually, the cutoff points, if you look at the Americans, they say 100, you can talk about statins. If it is more than 300, you have to start.
Okay. So let's say that she has calcium score that's positive. Would you go on with further investigations, or would you then hammer her to get the LDL down to what?
Hammer first.
Hammer first. Okay, so you don't need to do any further investigations.
Then you would like to do at least do a stress test to also look for ischemia.
Shamrus, any other thoughts?
But if she really doesn't have any symptoms at this point, calcium score would help to target the LDL better. Maybe reassess it in 3 to 6 months' time.
Okay, right. I'm going to just quickly show you some slides to tell you which is the latest data and very, very exciting evidence that shows that if you target the weight loss, that you might be able to improve many of the cardiovascular parameters we have been discussing, like sleep apnea and things like that. And just to tell you that diabetes is one of the great providers of patients going into CCU for ACS, all right, almost 50%. And again, just to remind everybody, unfortunately, it is causing morbidity. That our patients in Malaysia having cardiovascular disease are about 1 decade younger than what you see in the Caucasian countries. And individuals being admitted for acute coronary syndrome, about 8 out of 10 of them are either overweight or obese. So it is providing, unfortunately, a lot of morbidity. This is data to suggest that if the person on the left who has abdominal obesity is able to lose 30% of visceral fat, 30% of that visceral fat, they will be able to reduce all these elements that you see, such as improving lipid profile, improving insulin sensitivity, reducing A1C, inflammatory markers will drop, and endothelial dysfunction will improve. So we know from established studies that if you lose 30% of the visceral fat, you will be able to do that. Data to show that now we want predictors, we want outcome studies to show that if you use something that significantly impacts on weight reduction, you will impact on cardiovascular outcomes. And this is from diabetic individuals in the sustained 6 semaglutide 1 milligram, and you can see reduction in cardiovascular events by 26%. Significant. Diabetic patients either known to have cardiovascular disease or high risk of cardiovascular disease can have significant MACE reduction, right? And this, even more exciting, is the SELECT trial in patients with established cardiovascular disease, non-diabetics who went on into the trial with semaglutide 2.4 milligrams was able to reduce MACE by 20%. And the MACE outcomes were seen within 3 months of being on the trial, which suggests that we are not looking only at atherosclerosis reduction. Something is happening, perhaps more likely to be the inflammatory markers that we were talking about, okay? And just to remind everybody that the GLP-1 receptor agonists are the ones that are giving us the best outcome data for cardiovascular protection. All these 8 studies are cardiovascular outcome trials with different GLP-1s, and you will see the overall meta-analysis suggests that we are able to see a 16% reduction in MACE outcomes in these trials for cardiovascular benefit. Last but not least, it is tirzepatide.
Before you go from there, when you talk about semaglutide, there's a lot of my patients are agreeable to take oral semaglutide, but are very reluctant when it comes to the injection.
Yeah.
What are your thoughts?
Well, then it depends on how motivated they are to want the target organ protection we are talking about. If they are really serious about it, then they have to take some form of GLP-1. The oral semaglutide, which is currently what we have, is Rybelsus. Maximum dose up to 14 milligrams taken daily has also been shown to have cardiovascular protection. So if they opt for the oral version, by all means. So either one will be just as good, right? But they have to be willing to continue on it. Because remember, when you're taking this for the purpose of target organ protection, when you stop it, gone lah. So you can't say, wow, Dr. Prasad, I love you so much. I've lost so much weight. I look so much better. Can I stop the semaglutide? Your answer would be, why did you start taking this medication in the first place? If you started it for weight reduction, then perhaps we can have a chat about that. But if you started it because you are having cardiovascular disease, JR, Shamrose, or you have a high risk for cardiovascular disease and you want to have the benefit of reducing MACE, you do not stop it. That makes more sense, right? So you have to discuss with them, right? Okay, so the last but not least is this tirzepatide, Mounjaro. They did a cardiovascular outcome trial called SURPASS CVOT. SURPASS CVOT just read out sometime last year, late, okay? And it was a cardiovascular outcome trial using tirzepatide compared to an active comparator. The others were all placebo, okay? And the comparator was dulaglutide, okay? And they demonstrated cardiovascular benefits, significant reduction in all-cause mortality. Just to put you back to the background of dulaglutide cardiovascular outcome trial, which is called the REWIND trial. This is patients with diabetes, with the usual stuff, okay? And dulaglutide was positive. Dulaglutide was positive for reducing MACE. So dulaglutide is actually beneficial for cardiovascular protection. So if you look at it in that term, you will see that the patients who are on on tirzepatide did not find any difference between Mounjaro versus dulaglutide. You will then say tirzepatide gives you the same outcome as dula, which means that you should have cardiovascular benefit. So what they found was the overall MACE was not significant, but they found all-cause mortality was reduced. Okay? So obstructive sleep apnea, this is with tirzepatide, which is Mounjaro, and they were able to reduce in the dark blue columns 29 AHI, which is apnea-hypopnea index, and just a simple clinical outcome was patients who required PAP, 50% of them could stop PAP and still able to handle the OSA. And that's partly because of the significant weight reduction that was what they benefited from. Last but not least, MEFLD and MASH, all right? MEFLD and MASH, if you followed any of the trials looking at effectiveness and improvement of MASH, improvement of fibrosis score, this is a biopsy-proven study called the ESSENCE. They did two parts. Part 2 is happening. Now this is the outcome for part 1. They biopsied the patients at the beginning. They biopsied the patient at week 72, and they were able to find 63% had MASH resolution and 37% had fibrosis improvement. This is probably the second drug that is able to show improvement in MASH in patients with more than just MEFLD, okay? So this is really very, very exciting data and will change management of patients. Yeah, please.
Okay, looking at that trial, it's very interesting, but is there any link to the HbA1c, or just don't even bother to look at it?
Good question. Not linked to parameter improvement, not linked to weight reduction. That's what they found, okay? That's what they say, all right? We'll look at some more data as it comes out. Very good question, right? But again, very, very exciting, because before this, nothing else was able to show improvement in these biopsy patients. So last but not least, you need to have this. If you're able to lose a significant amount of weight, you will have all these other benefits. If you lose more than 15%, you have type 2 diabetes remission, you have cardiovascular mortality reduction, HFpEF improvement. So the degree of weight reduction will give you different results, okay? With that, I'm finished. I think one more talk, fixing one of the problems that we always knew was correlating with morbidity, all the things that we are talking about, the weight and everything. If you fix them upstream, you may be able to fix most of the problems. Jaya, thank you.
Yeah. Dr. S.P. Chan is going to run off in a little while. Anybody got any questions about the newer drugs and stuff like that she's going to talk about? Yes, go.
Hi, good question. Good case scenario, and I think it's quite relevant to our clinical practice. But the question always been asked. Everybody agreed that lifestyle diet is very important, especially diet. What kind of diet do you think we should advise patients to adhere to? There are many types, like ketogenic diet, intermittent fasting, low glycemic index diet. What is your comment?
Okay, good question. Which diet is superior to the other? The answer is none. The key to losing weight really is eating less. How you do it does not seem to matter, right? If you go on ketogenic diet, it may give you a more rapid rate reduction initially over the first 1-3 months or even 6 months. But the unfortunate fact is that it bounces back up. Whatever kind of dietary regime you go on, it will happen. And the reason being, right, our bodies are against us. The reason why, S.P. Chan still looks like she looks, okay? The problem is when you lose weight, your body compensates to regain that weight. What it does, it reduces your basal metabolic rate. It tells you are hungry and that you will be looking for food. So the compensatory mechanism, defense mechanism that the body seeks is to regain the lost weight. And then that's the reason why you become more metabolic efficient. So to do the same things, if you want to try and keep the weight down, you have to do even harder to keep that weight down. So unfortunately, that's what we have found.
Right.
And the reason why some of these medications are able to successfully get patients to keep that weight down while they're taking is that it wipes out that satiety drive, those problems, those drives.
You stop it, do you put on back the weight?
Yeah, you do. It comes back, but it doesn't bounce back up. It will come back slow and steady, but eventually it will come back.
Okay, all right. Thank you, Dr. Chan. We will move on to the next session, which is more focused on case 2. And okay, this is a more common sort of scenario that we see. 45-year-old man comes for a normal checkup. He claims he's well, but he admits he's more tired and lethargic of late, can't sleep well, very stressed at work, a lot of deadlines, no past history of note, smokes and vapes occasionally, no exercise. Father died suddenly at 50 years, was told he was a heavy smoker. Mother is alive and patient is the younger of 2 children. Okay, Shamrus, a lot of our patients are giving up smoking and moving to vaping. Is it bad? And what are the health risks if it's so?
Well, it's not harmless. So if you haven't started vaping, don't start. I mean, we don't really have long-term data at this point, but we know with vaping, sometimes you're exposed to more nicotine concentration, and we know nicotine affects the heart. So increase your heart rate, increase your blood pressure, can lead to hypertension, arrhythmia. It affects your vessel, causes vessel inflammation, endothelial dysfunction. So all these risk factors are consistent with the traditional cigarette smoking. But in addition, in vaping, you have all this flavoring, some heavy metals, so we don't know the long-term impact of these things upon your heart and your lung. I mean, certainly you can get lung injuries, psychological disorders, difficulty sleeping, it's been associated with anxiety issues as well, arrhythmia, so there are many things. So, but if you ask, if I'm a smoker now, can I use vaping as an intermediate step to stop smoking in the end? So NICE guidelines actually allow vaping temporarily as a harm reduction tool, but not to overtake smoking. So you still have to stop, but compared to traditional smoking in terms of carcinogens and all that, of course, vaping is considered less harmful, but temporary measure.
Okay, his father died at 50 years. Is that important?
Yes, it's a risk factor for cardiovascular disease, male less than 55, female less than 65.
Okay, his height is 187, weight 96, BMI 26, a bit of tachycardia 92, and BP is as shown. So now, the first thing, Shamruz and Prasad, there's so many hypertension guidelines. Which we follow? American, European, our own? Tell us something about it. Who wants to start first? Okay, Shamruz first, or Prasad first, whoever.
So many, I mean, American, European, Asian, society-specific, WHO. I think generally Americans are more aggressive. I think 130/80 is the cutoff now for hypertension, and for you to start lifestyle changes, maybe medications. But I think Asian, Europeans still using 140/90. I'm not sure about our latest guidelines that will come up soon. Maybe Dr. Jaya, you have more information. Dr. Prasad?
Right. Even if you look at our Malaysian guidelines, this was actually from 2018. They mentioned 140/90 as the cutoff for diagnosis of blood pressures. In Australia too, actually, if I'm not mistaken, it's 140/90, and anything below that. And if when you control, you have to control it below 130 or 140/90, and for high-risk patients below 130/80. But the European Society of Cardiology, I think Jay has just put this up. This is ESC guidelines, and as you can see now, anything, as Shamruz was saying, the new guidelines, anything more than 130 is already considered to be hypertensive. So, they're shifting the goalposts very fast, and most of us senior citizens try to look at the older guidelines, but now I suppose we have to update ourselves and also look at you can see the guideline Jay has just put up, where it says that anything above 140/90 is already considered hypertension and must start treatment. Between 120 to 140, you can follow all the lifestyle modifications, etc., etc.
They are getting very aggressive now, actually. Okay, this man, as I pointed out to you, has a resting tachycardia. Is this important, and what is the significance of it?
I mean, resting tachycardia alone is an independent risk factor for cardiovascular event. For him, he's a smoker. I mean, if he's vaping, if he vapes too much, nicotine, as I said earlier, can cause tachycardia. You need to check whether he has underlying arrhythmia. Simple ECG can show you that. When he has underlying heart failure, you can also have resting tachycardia because of that. A few reasons that you need to investigate.
So it may not only just be anxiety coming to see you.
I mean, you can ask him to relax for a while and then recheck the heart rate and BP.
So every parameter has to be taken into consideration. Okay, Prasad, what is this man's target BP according to the traditional guidelines? He's seeing you for the first time, huh?
Right. As I said, when he comes for the first time and I get a blood pressure like this, I definitely will not consider starting him on any therapy. But definitely, I would look at him. Look at his BMI is slightly on the high side, and he's got a resting tachycardia. So I'd want him to start lifestyle modification, make sure that he loses weight, control his diet, control his salt intake, talk to him about getting adequate sleep and so on and so forth, stop smoking, and then monitor him and see whether his blood pressure comes down. At this point of time, I would not start any medication, but I would like to get his blood pressure down to about 130/80.
Yeah, even the Europeans say, first time, no, you have to counter check to make sure that really it is elevated before they would brand it as hypertensive. Hemoglobin is high. Is this a cause, and what do you think? And as a GP, what would you do and advise the patient? Shamruz.
I mean, by definition, the PCV and hemoglobin are elevated. So he has polycythemia, but you need to check why he has polycythemia. Common causes needs to be excluded first, like simple things like dehydration. He's a smoker, whether he has underlying OSA or not. I mean, look into all these things first before looking into the main, like polycythemia rubra vera and things like that.
Yeah, the other thing is whether he snores, like we have talked about earlier, hypoxia at night. So these are few things. You see, every little abnormality tells you something about the patient. So his kidneys. Prasad, are you happy with the EGFR and the creatinine, or do you think as a GP I should be quite happy and tell him your kidney is okay?
Well, first of all, he's 45 years of age. And at that age, normally, GFR of 90 doesn't ring any alarm bells. But let me tell you that at that age, normally the GFR is always more than 100. It's 100 and more. Of course, you're not going to run into a panic of worry your patient by telling him, hey, your kidneys are damaged. But definitely, I would like to look, what does the urine test show? We've not done a urine analysis here, and whether we can do a urine test. Okay, you've done a urine test here. There's no proteinuria, 1 to 2 RBCs, which is probably not significant. He has 10 WBCs, which is high in a male. Of course, the cause is not obvious here, but I would like to do an ultrasonography to look at the whether there's any silent stones or anything causing that asymptomatic pyuria. But again, here this is a dipstick test, so it's not fully accurate.
Yeah, but do you think it's some prostatitis? Could that be also a cause for the WBC? Don't know.
We don't know. I mean, you could, let's say you can do a digital rectal examination to see whether there's any tenderness of the prostate, an ultrasound to see whether there are any silent stones, etc.
Okay, is a urine dipstick for protein good enough?
No, answer is no. In fact, if you look at all these, many of our guidelines, especially if you look at the Australian hypertension guidelines, anytime a patient is diagnosed with hypertension, they advise you to do a urine ACR, albumin creatinine ratio.
And how do you do that urine ACR?
Well, it is actually you can do it with a dipstick called a micral dipstick, but that's expensive. But now most of the labs will actually do the albumin creatinine ratio for you if you ask for it. Even SJMC will do it, and all the private labs, InnerQuest, Path Lab, whatever, they all do the albumin creatinine ratio for you.
So this guy's urine ACR is 20 milligram per 100 gram. Is that okay? Is that not okay?
Okay. So basically, he has got microalbuminuria. Now, the normal ACR will be less than 3 or 3.4, and if it's above 30 or 34, then it's gross proteinuria. In between, you call it microalbuminuria. So microalbuminuria is actually already a sign that there is some involvement of the kidneys. So we are not going to label him as absolutely normal.
The presence of the white cells in the urine, will that confound your ACR?
A little bit, yes, but here there is not gross. 10 WBCs is not a lot. But if you have a few hundred WBC or 1,500 WBCs, yes, it can be a confounding factor, in which case investigate, treat if necessary, and then repeat the ACR.
Okay. Okay, Shamrus, I'm a general practitioner. Is this all enough? Because, of course, one of the big things we talked about is cardiovascular morbidity, mortality. What would you do, or what would you, if you were a GP, think you should do?
Okay, I mean, there's always the traditional risk factors, family history, smoking, hypertension, diabetes, cholesterol. But nowadays you can consider risk factors enhancers like inflammatory markers if you're worried about his risk stratification, calcium scoring. But simple things in clinic would be ECG. See whether there's any obvious resting abnormality, prolonged QT, any silent ischemia, previous silent infarct, things like this you can pick up from ECG. But it's not very sensitive, okay?
So ECG was normal. So these were some of the things you asked for.
Before that, you see, we mentioned the ACR, and I mentioned earlier as well, any presence of proteinuria, even microalbuminuria, has been shown. If you look at a PREVENT study from Netherlands, a community-based study, they found anybody who had proteinuria, even microalbuminuria, microalbuminuria had more incidence of heart disease in the long term. I think that's very well established now.
So this guy already has shown something lah. Okay, yes. Can you comment on the results and your advice, Shamrus? This guy's sugar, lipids.
Yeah, so he's got a few things now. He's a smoker, he's got polycythemia, he's got resting tachycardia, he's got microalbuminuria, and now he's got borderline sugar, HbA1c 5.9. His LDL is also not controlled, HDL is low, triglyceride is also elevated. So all these are risk factors that you need to manage. You know, lifestyle modification, the usual first step things, and reassess him.
I see. Okay, so you say lifestyle modification. So at this stage, you wouldn't want to start him on any medications? This is the second visit to you. Not yet.
But if I'm very worried, with the cholesterol like that, I may consider calcium score, and that may change my plan with regards to statin. But at this point, maybe not, reassess.
Okay, does he have CKM? Dr. Prasad, you are the...
I'm not the expert, but yes, I think he has definitely got cardiovascular kidney metabolic syndrome, and it's not even stage 0 because, as you can see, he has got dyslipidemia, he is overweight, he's a smoker. So I think definitely he has got cardiovascular kidney metabolic syndrome. And you can see that it's probably stage 2 to 3 now. Yeah.
Yeah, stage 2 to 3. Yeah, you're correct. Okay. So, yeah, anything? I think you did mention about your calcium score or whatever earlier, right? Okay. So basically, just to your cardio-kidney metabolic syndrome. So basically, talking about looking for calcium score and the heart failure echo. You did mention that. Okay, somebody talked about inflammatory marker. So this HSCRP was thrown in, 6 milligram per liter. What are your views and what is your advice, and is it going to change your management?
I mean, HSCRP is a risk factor enhancement. It's like ApoB and things like that. So in very low risk patient, no point. Very high risk patient, no point. It's more for borderline intermediate group of patients where you want to risk stratify these patients further. I mean, with whatever we have so far, I already know he has risk factors. Okay, but if it's not convenient, maybe with regards to starting after lifestyle modification, with the elevated HSCRP, it's even more reason for him to be more aggressive in terms of the LDL reduction, weight reduction, smoking cessation, and controlling his sugar better.
So basically, it's used to threaten the patient lah.
Actually, I've been asked a few times about this. You see, there's two things here. One is the CRP, which we normally do, which is actually an inflammatory marker for high level, for infections, etc., etc. But that is not going to be very useful in a scenario like this. So in a scenario like this, especially if they've got cardiovascular kidney metabolic syndrome, stage 0 or stage 1, as Shamru said, that would be the place where we actually can look at the HSCRP. And if the high sensitive CRP is less than 1, then usually they're at very little risk. If it's more than 3, they are at high risk. Between 1 and 3 is the intermediate, and that's where you can do. And this inflammatory marker, as I mentioned earlier, comes from the substances produced from your adipose tissue, exactly. So that's what causes to makes this CRP high, and that's why you can, at that time, you know, this apple-shaped body, as I've mentioned.
So tell him to reduce weight first. Okay, so the second visit is, the first visit, the BP was 145/89. Second visit, 140/85, 140/85. Would you treat the BP now?
Okay. Again, you see, this is his second visit, and I find that his weight is probably not come down. He's, in fact, if I look at it, his weight has actually gone up, isn't it? Has it gone up?
Not much. It is just about 1 week's difference.
Oh, 1 week difference. So I think even when you lifestyle modifications, I think you should wait at least a few months, 3 months, before you decide. So in this case, I would probably not rush in and treat him. I would just continue lifestyle modifications, emphasize all the various things, including the fact that he has a elevated CRP, and if we don't do anything, he will end up with cardiovascular disease.
Prasad, sorry, just a quick one. With the urine ACR, microalbuminuria, isn't that a target organ damage already? Would it be considered as a high-risk patient under the ACC guidelines and you start treatment just because it's above 130/80?
Yeah, actually, you're right. Once the urine ACR is positive, there's always a case to be made to consider starting an ACE-ARB in order to reduce this. And usually very low doses of ACE-ARB suffice if the patient is open to the idea. Otherwise, again, we go with weight loss. And I think SP Chan showed her slide where patients with weight loss, whether it's with drugs or with whatever reason, there will be improvement in most of the parameters.
Okay, the European guidelines are more aggressive. If the second visit it's still high and is above 140, they have advised that you start treatment. But that's being very aggressive. In the interest of time, I'll just run off. Okay, just something about home BP, which I think is very important. Now, this guy, okay, says he measures his BP at home, and 135/85, 125, he says, I'm very good. And that's the clinic BP. So, Dr. Prasad, what is this difference between home BP and the office BP, and how do you reconcile the two?
Well, office BP is always, the home BP, if the instrument is accurate, which I always ask my patient to bring their instrument in and I check it in my clinic, it's actually home blood pressures are usually about 5 millimeters lower than the office blood pressure that we measure. So if your blood pressure at home is good, because then you can get rid of the notion of white coat hypertension, etc. So office blood pressure is something that we are comfortable because we are measuring it ourselves. But if the patient maintains a good record of home blood pressure monitoring, measures it twice a day, 2 readings, take the average, etc., then it'll be quite okay to look at the home blood pressure reading before we commence therapy.
So it's according to the guidelines, they say if it is above 135/85 is considered blood pressure. But I agree with you, I find home BP very helpful. Just refuses medication, insists on lifestyle changes, as all our patients do, comes back 1 year later, no better, still stressed, smoking, and his weight has increased, and that is his blood pressure. Would you treat it now?
Yeah,
Shamros?
definitely. Yeah.
Okay. I'll move on to the next question. That is, would you now, of course, you have decided you're going to treat his blood pressure, and what is your target?
Okay, as Shamrus has suggested, we will start treatment at this stage, and we will usually, the guidelines now suggest starting low-dose combination therapy. In the olden days, we used to start ACE or ARB, push it up to the maximum, and then, if not controlled, add on maybe a CCB or diuretic. But now, the current recommendation is to start a combination, low-dose combination therapy, ACE, ARB, plus either a diuretic or a CCB. The target now remains the same. You should bring it to below 130/80. And especially because he's got, I can see his albuminuria is increasing. So we are definitely worried. And in fact, now if you look at it, he's got gross proteinuria already. No more microscopic albuminuria. So we should treat the patient and bring the BP down to 130/80. Continue lifestyle changes as before.
Okay, can I stop my BP medicine?
Over my dead body, I think.
Okay.
No, I think that's a very common question. All of us, a patient sometimes on their own stop it. 2 reasons they will give you. Number 1, I checked my BP at home, is normal. But I keep telling them that it is normal because you're on medication. Number 2, sometimes they do cut down, they stop their medication because they say, I feel giddy, doctor. And now, if that's the case, then you have to check for postural hypotension. Ask them also to check at home for postural hypotension. And if if you think that it exists, cut down the medication, not stop it completely.
Okay, last question, sir. Blood pressure, sugar, and lipids. How would you treat? And if the lipid parameter, what would you target? LDL, TG? Because earlier we talked about the metabolic syndrome and this CKM, and we said TG is good, is important.
Yeah, I mean, definitely at this point, without knowing whether he has underlying CAD, the LDL target needs to be at least below 2.6. You can do calcium score to further improve the target. The TG should be below 1.7. I asked SP Chan the other day about this HbA1c. She said she would start treatment for diabetes as well at this point.
Yeah. Because there are some studies that if you maintain normoglycemia, they actually do well long term. So, refuses statins.
Okay, I mean, these common issues in the clinic. I mean, first of all, find out what is the problems, whether it's more here and say from what they Google, from what the friends told them, find out the real reason and tell them, you know, a majority of patients actually tolerated statin very well. The serious side effects like liver injury, less than 1%, you know, myalgia, maybe 5 to 10%. Can always change brand, change dosing, you know, alternate the days initially until they tolerate it better. If you really, really cannot, and you're very high-risk patient nowadays, you also have the options to go for injectables, which, but of course, they are costlier.
Yeah. Okay, so, yeah, because it damages the kidneys. Does that damage kidneys?
Absolutely not. But actually, this is not uncommon. You see, I mean, if you look at, if you go and stroll the internet, you will find a lot of literature saying how bad statins are for you. Kannan will write a lot of things in the newspaper, Star newspaper, how good statins are for you, and then somebody else will write in and say, oh, this is all very wrong, and I remember that very clearly. This happened many years ago in the Star newspaper. Now, so the worst thing is, when I tell them, why did you stop? He said, no, I never started. Why? Oh, because my friend told me, my Grab driver told me, this fella told me, and then they don't take drugs because it's bad for the kidneys. And it's not any kidney specialist or any GP or any doctor who has said it. These are all done by...
Next-door neighbor.
Yes, next-door neighbor, correct.
Yeah, and actually there's a study which just came out in Lancet which showed that actually the adverse effects of statins is really very minimal. That is actually very safe drugs.
Yeah,
Okay.
there was one talk when I went, I told you, I think I did tell you about it, where some people suggested patients who have got myalgia with statin to try using coenzyme Q10, and apparently it helps. Do you know anything about that?
Okay, this is all anecdotal, and in fact, even in our guidelines, we have said, if you think it helps, there's no big data, no large randomized trials, but again, there are small studies which seem to show that in certain individuals, it's supposed to help your myalgia. If it helps you, well and good, just continue. If it doesn't, you can stop this coenzyme Q10, but there are other ways, like Shamruz has alluded to, taking it alternate day, bringing down the dose, changing to a different type, which may help with the myalgias. Yeah. Okay, so basically the take-home messages: prevent cardiovascular disease in all. That means eat well, exercise, be careful with your sugar, weight, blood pressure, lipids, stop smoking, and sleep well. And don't fight with your next door neighbor or your driver. Once you begin to put on weight, treat central obesity and clinical obesity early, and treat all the metabolic disorders early and appropriately. Identify and treat subclinical cardiovascular disease early and appropriately. And by subclinical disease, of course, the resting ECG gives you some idea, but increasingly we find doing calcium score unearths a lot of things that we never suspected before. And hopefully with these measures, we can prevent clinical cardiovascular disease. Thank you very much. And are there any questions? No. If not, thank you very much, Shamruz, and thank you, Prasad. Yes, there's somebody wants to ask. Yes, sir. Unfortunately, no. If the patient has got multiple CV risk factors, and especially with a family history of premature cardiovascular disease, you may be something that you may want to ask to do. Okay, now LP little a, I think Kannan the Great will talk about in his next chapter. The use of LP little a is in patients who already have clinical events or who already have high cholesterol, to try to convince them to take. If the LP little a is above 50, then people will say that you do need to bring it lower. Right now, we don't have very effective medications to bring down LP little a. That's number one. Number two, the evidence for calcium score is better to help to justify the use of statins rather than the use of LP little a. LP little a still as a risk modifier. Okay, one of the risk modifiers. According to the latest guidelines, whatever age to the less than, I think it's less than 70 or 75, I think they try to aim for 130/80, but if the patient is frail, okay, then you have to maybe accept slightly higher. In the good old days, it was 150 lah, 160 lah, now all no more already. How frail the person is. Okay, I think we will stop for tea break. One more. Yes, sir. Yes, sir. One more question. Sorry.
Question. This one is regards statin. I just rushed out just now as Prof. Chan was leaving. I asked her the same question. It's about statin. To take it on a daily basis, or we can take it alternatively, like for example, a few days once, or maybe once a week. And she gave me a dressing down just now. She said, if you were to take it alternatively, don't come and see me. You know. Anyway, what's your opinion on it? This one is regards a patient of mine who is about 59 years old, male. Yeah, he developed diabetes just about a year ago, and he has hypertension for about 5 years. He's on Mercadis 40 milligram once a day. He has central obesity. He has a very laid-back kind of a lifestyle. He doesn't exercise much. And there are no other abnormalities that we can see. But then his cholesterol was high, triglyceride 3.6 or so. And he had previously taken statins like simvastatin, and then his lipid, his liver enzymes are all gone. So he was asked to take atorvastatin, then it has become stabilized. But then because it's costly and he doesn't feel that he wants to continue. Now his cholesterol level is about 5.6. What's your opinion? Thank you.
Okay, if his cholesterol is 5.6, it definitely needs something to bring it lower. If the only reason for wanting to cut down the dose is if it's got side effects, and if you think the liver enzyme abnormality is due to the statins, of course the liver abnormality could be due to his diabetes, could be due to his central obesity, that's a different issue. But if you think it's definitely due to his statins, then one of the things, yes, you can reduce the dose. Short-acting statins, such as simvastatin, and I think should not be taken on an alternate day. Longer-acting, like atorvastatin, rosuvastatin, you can take occasionally in every other day, but you're only going to do it because if you take every other day, most times you forget, and the patient ends up not taking. Okay? So you only do it if you think the patient has side effects due to the medication. That's my answer. Okay, all right, so we'll stop for tea, and it's just outside. Oh yeah, sorry. Someone mentioned about high saturated fat as a risk factor, but the new food pyramid recommends meat, butter, and dairy. What is your opinion? Anybody wants to take that? Okay, maybe I can say something with it. Actually, the problem is when they said all this high saturated fat is correct, it's actually what you eat. When you said you can't take all your high substituted it with high carbohydrates. And when they started taking high carbohydrates, people began to get central obesity, diabetes, and stuff like that. So as a result, now people actually don't talk about high saturated fat. Okay, they say you can eat in moderation, because when you eat things like meat, butter, dairy, it fills you up. Whereas when you take high carbohydrate, you tend to eat more and you tend to put on weight and develop diabetes. So one of the reasons, in fact, even in 2020, there was already a shift that when they said that, don't have, all your sausages and all that, they said last time was bad. Now they said it is better than for you to just take 5 slices of bread with a lot of cheese and butter and stuff like that. Okay, so that's why the little shift.
I think the processed meat is still something that you want to avoid.
Yes.
When you talk about trans fats, this is all in our saturated, processed meat and all that is something that we should still try and avoid. And also when you talk about taking meat, I think meat is all right as long as you try and take meat which is not fatty part. Try and avoid the fatty part of meat. That's about it.
All right. Okay, we will meet back after the tea break. Thank you.